I think we'll go ahead and get started. Hi, this is Drew Olivera. I'm the Executive Director of the Washington Health Alliance, and today we have a presentation on chronic kidney disease. A couple of great panelists will be joining us and talk about it from sort of the employer perspective, a little bit of background about what kidney disease is and how it, how we stratify that or classify that, but really trying to get a conversation on what the best practices are from a screening standpoint, and what do you do as an employer? What are the pieces in there as well? We want to thank Bayer for sponsoring this webinar with us, and we might as well we'll just go into it and go from there. First, a couple of housekeeping pieces. We've muted all of you who are participants, so yeah, you can talk all you want and we won't hear you. However, feel free to use the Q&A. We'll look at that hopefully at the end if we have some time. If not, we will follow up and try to answer 100% of those that come in. Everyone will get a copy of the slides who registered, so you don't need to take notes or take screenshots or things like that, like people want to do. I also want to put a little plug in for the Alliance. We do a few things. We do public reporting. We also try to create value. And so part of this, this discussion today is from an education standpoint, how do we share ideas? How do we share best practices? And if we can do that effectively, we can convey and catalyze the market to also do some of those same things. So if you're not part of the Alliance today, we encourage you to join us and engage and help us drive quality and affordability in Washington. Just the next slide is just a couple of upcoming events. So we do have a similar webinar on colon cancer and colon cancer screening, a very important area in our state. Certainly got impacted by the pandemic. We'll have more seminars coming up as we get into 24, substance use disorder, a big push on women's health, and a few other initiatives as we go forward. We just changed our website, so hopefully that's easier for you to navigate, find some of the content and information out there that will help you and your either your practices and or your businesses be successful. Feel free to ask us questions or give us feedback on that. We have a number of committees that are part of the Alliance as well that you may, as you join, may find that that's a good place for you to share your expertise as we go forward. So let's talk about the agenda that we have today. So I'll start off and we'll talk a little bit about, sort of what chronic kidney disease is, the prevalence and things like that. But what we really want to get into is talking about, a best practice in the state. And Jennifer Jackals is joining us because one of their clinics really, does phenomenally well, and want to learn from that case and learn what they do and sort of how they went about placing that in their practice. And then I'm also joined by Michael Shannon, who has an interesting position as he's both a physician, but he's also running sort of the self-insured health plan for his organization of 26,000 employees. And that puts him in a unique position about how do I manage this important area as well. We'll stop and take some questions and sort of share that discussion together in a panel discussion. Throughout this this webinar, we're going to ask you some poll questions, and we'll even have one right toward the end. So don't leave too early. But let's start with the first one. And so that first poll question should pop up on your screen. You should be able to see that and answer that. And here it comes. And for those that may be on their phone and not being able to see it, it's talking about the different stages of chronic kidney disease, which we'll talk about. Stage 5 is worse than stage 1. The question is, does it cost any different, stage 5 to stage 1? Is it more expensive? The answer is yes, but how much more? And feel free to put your thoughts, your answers in there, and then we'll see what the poll shows. And we're seeing a bunch of things come through. Most people are saying it's cost 20 times more, um, for end stage renal disease versus sort of the early stages. And we'll see what, as we go through, and Dr. Shannon will talk about this a little bit. We'll see how close you are. And we'll go from there. But thanks for doing that poll. There'll be a couple more as we move on. So let's talk about kidney disease, and I'll go pretty quickly. You'll get these slides, but about a third of the adult population is at risk, and why is that? Because hypertension, diabetes are some of the primary causes of chronic kidney disease. A number of people are undiagnosed because it can be asymptomatic. You may not know you have it, so you have to be screened for it, and you have to be purposely. You wouldn't screen 100% of the population, but certainly if you're at risk, you should get screening. We talked about costs a little bit, and these costs feel low to me, but they're in with B's, not M's, so they're billions of dollars. Pretty important. And people with type 2 diabetes, about a third of them actually will have chronic kidney disease. And so screening is really important for that population as well. And by itself, chronic kidney disease is an independent risk factor for coronary artery disease. So again, another reason we should pay attention to that screening process, catching things early. But let's talk about the kidney a little bit just for fun. Because some people, go, yeah, I know I got a kidney, or maybe I have 2 kidneys, maybe I have 3 kidneys. What do? Well, the first thing they do is they filter our blood. So they filter about 14% of the blood supply every minute. I mean, it is flying through there, and it's filtering that. And so filtering is great. It can, remove all that waste and impurities, in our system, and then we're good to go. But if we only filtered, we would be dehydrated really quick. So it also has to, if you click one more time, it has to collect and return most of those fluids back into the body, and separate out the waste that's there. And essentially it does this for the reason, if you click one more time or 2 more times, is to maintain our status quo, or our homeostasis, if you will. And the kidneys really are the most important things in terms of our salt balance, our pH, getting rid of the dead cells in our body, urea, but it also does a few other things that you may not be aware of. It helps regulate blood pressure. It regulates our red blood cell count, our red blood cell production, and it has an impact on bone mineral metabolism. So our calcium level, our bone strength, our bone density. So kidneys are pretty important little organs to have with us. And to understand that, if you go to the next slide, it's important from a screening standpoint that we screen people, because they can be asymptomatic. People with diabetes can spill protein, or what we call albuminuria, and that if they start doing that, their risk for heart disease and heart attacks go up as well. So let's talk very quickly about the different stages of chronic kidney disease, and they're really just 5. So the next slide, what you'll see is stage 1 is pretty normal functioning kidneys, so that's great. But as you move down, what you'll see in sort of the stoplight version is as you filter less well, that is going to impact that kidney function, impact its ability to do what we talked about before: ability to filter, ability to collect waste and remove waste from the system. And as you get all the way down to stage 5, you're not being able to remove much fluid at all, and you can have fluid buildup and things like that. So how do people feel when they have one of these stages? The next slide, if we look at stage 1, pretty normal functioning, that people are asymptomatic. But what you want to do if they've got a chronic condition is you want to actively manage those conditions. They have high blood pressure, diabetes. You want to make sure that they're well managed, well under control. Blood pressure is normal, diabetes is managed well. You also want to make sure that they're eating an appropriate diet, they're exercising. You don't want people smoking. We were just talking about that a second ago, because that can actually impair some of the blood supply and constriction to the kidneys. You want people to be normal weight. So if you're asymptomatic and you've got a chronic condition, you want to be managing your chronic condition as well as possible. Now, Now we're starting to get into the yellow areas, those stage twos. A lot of people are very asymptomatic with this. It's slow progression. They may be adjusted to any symptoms that might be there. The treatment is still the same. You want to continue to manage those chronic conditions. So most people are asymptomatic in stage two, and again, it's just focusing on those conditions. If you go to the next slide, we start talking about stage three. Now, here's where people start. You start seeing the kidneys not filtering well. People may have these vague symptoms: fatigue, back pain. They might not be hungry. They may not be able to sleep. They may not notice that that's a change because it's so slow to happen. Screening this population is really important because now you can, if there's a possibility to treat the underlying cause, you can do that. But you also want to monitor for things that the kidney does. Are they anemic? What's their bone mineral density? Do they need to be on a different diet than they've been on to lessen the work of the kidneys? All those things are really important. So screening becomes more important. And then the next slide, stages 4 and 5, you're getting to where there's severe impairment. Most people have symptoms at this point. They could be, things like, itching or shortness of breath. You're really now talking about, do they need to go on dialysis or not? What would that look like? You should have those conversations about, potential renal transplant early, where dialysis occurs. Is it in the home or is it in a facility? And then what type of dialysis would that person need? But what we're trying to do is prevent people from ever, getting to this end stage as well as possible, or at least delaying that as much as possible. So that's sort of the thought process on chronic kidney disease. So let's see what the impact might be on different ethnic groups. And if you go to the next slide, all groups are not created equal. So African Americans are 4 times more likely than white Americans to develop renal failure. Hispanics more likely than whites, and it is increasing within that population. First Nation, American Indians, Alaska Natives, more likely than whites, more likely to have diabetes as a leading cause. But some of that population is being treated very aggressively, and you see great reductions in that. Even Asian populations have a higher risk than the white population, usually due to diabetes. And then, Native Hawaiian Pacific Islanders, again, a higher risk of diabetes, higher risk than even than blacks for getting end-stage renal disease. So the impact of your race and ethnicity can have a severe impact on kidney disease, and even more important that you look at that. But let's look at a little bit of data. So some data that we've found from the Alliance on the next slide. We looked at, how well are we screening people in Washington? And the two colors here, blue is the commercial population, orange is the Medicaid population. And this is looking at adults under, age of 65. And, and the other thing that you note here is these different bars going across. So from left to right, that is where you live, and where you live in terms of how deprived that area is in terms of the geography that person lives in. So it can be income level, housing shortages, housing might be worse, education levels. It uses what's called the Area Deprivation Index. Was developed actually by HRSA and applied by the University of Wisconsin at a level so that we can start looking at, what effect does where you live have an impact on quality. And you can sort of see a downward trend, certainly on the commercial side. As you move into a more deprived area, you're getting screened less. That might be because they don't have providers in that area, and there may be a number of other factors. What we know about those populations, they tend to have a higher rate of chronic disease, probably should be screened more. And you sort of see that on the Medicaid population. Overall, screening rates are low. They're under 40% across the state. So we have a ways to go. These are people that should all be screened annually. If you look at the next slide, very similar. Now we're looking at an older population at the top, and then all populations of diabetics are they getting screened. And you can see in the older population doesn't look that different than the younger. And overall, it gets worse depending on how where you live in terms of your screening rates. And so then we asked, are people being managed well? So the next slide gives us a look at how well people are being managed with their diabetes. And if you just click one more time, um, 83% of the time people are being tested, 60% of the time people are getting an appropriate eye exam, 65% of the time, and this is for the commercial population, people are taking their medication. So there's a ways to go in terms of actively managing that population. The next slide looks at hypertension. Maybe we're just managing hypertension well, and what you'll see if you click one more time is that we got a little ways to go on that. About 77% of the commercial population is taking their medications and refilling them appropriately. It doesn't seem to make a difference where they live. So that part, I think, from an equity standpoint, is really good. And then the last slide that I'm going to share is what happens if you don't have a primary care provider. And if you don't have a primary care provider, that's the center graph, if you will. Very few people are getting screened. And in fact, if you click one more time, it's under 25% of people with diabetes are even getting screened for kidney disease. That makes a lot of sense. You don't have a primary care provider. If you do, which is on the right, a lot of people are still being screened a little bit higher than the state average. But that's what we really want to try to get at is how do we get more people screened? Now, I'm showing you data that's statewide where we're seeing screening rates in the 40% range. And I'd like to introduce Jennifer to talk about what they've done in their practices. And Jennifer is the clinical quality manager at the Everett Clinic and the Polyclinic. She's got over 30 years of experience. And really what we want to talk to her about and learn from her is that those practices screen 50% better than everybody else. And so they're doing something actively that's very different than the average practice in the population. And we'd love to learn a little bit about, why might that be? And what are you guys doing to address that? And so anyway, I'd like to welcome Jennifer, and thank you for joining us.
Thanks for having me. Excited to be here and to share some of the learnings we've worked on over the years, especially in quality improvement. It's not a quick process sometimes to get there, but let's go to the next slide. So I'm going to talk about kind of looking at working with the clinic that was identified and just all of our other clinics, trying to understand what were the key influencers in being successful for chronic kidney disease monitoring and evaluation. And so these are the places I'm going to focus on: the electronic medical record, education, making sure we teams have the right data to see how they're performing, how to utilize the whole team in caring for the patient, and then incentivizing good quality care. Next slide. So I'm going to start with the electronic medical record, which is really can be has many capabilities, and I think sometimes I look at it as a high performing machine that if you know how to run it well, it can be super powerful and help you to do lots of things. It can also feel overwhelming and burdensome if it's not optimized to the best use. So in clinical quality, we work closely with Epic, which is our EMR that we use, and we work to fully utilize it. And so we work with them to develop these health maintenance prompts and modifiers. And this is each patient that comes through has their own personalized prompts that are auto-generated with Epic, depending on their age, their sex, and their medical history. So it would identify a patient as diabetic, or if you're a female who is 50, do you need a mammogram? So it'll have a prompt listed to help kind of identify these things we definitely want to screen and monitor for. And we also have a prompt for kidney disease monitoring, and this reminds the provider to evaluate that yearly evaluation, blood and urine tests to monitor kidney health. We also utilize things like smart sets and preference lists, and this might also important if you don't have Epic, but or like dot phrases, that things that add information in for either the provider or for the patient in the after visit summary, which I'll talk about a little bit more. But it really is a huge tool that kind of takes some of the trying to remember what people are due for, where it lists it all nicely out and exactly what it is that we want to screen for every year. Next slide. And then we also have created, we want to provide teams with real time data so they can really see how they're performing and managing care. So we worked with our analytics team and we created a dashboard that's accessible to our providers and to the clinical teams. And this dashboard's comprised of several clinical quality measures. And you Dr. Oliveira touched on some of these before, where we utilize HEDIS, or Healthcare Effectiveness Data Information Set, which is a widely used tool to measure healthcare performance. And we go through and look at the measures that we're going to focus on, and then we create this dashboard and we look at it gets updated every year, kind of what the goals are, what's the benchmarking, what the measures are, and we update that dashboard so people can see how they're performing. And it refreshes daily. You can filter it down to a provider, a location, a specific measure. So if I wanted to see if I'm a provider and I want to see how I'm doing on kidney health evaluation for patients with diabetes, I could look and see how I'm doing on that measure, how many patients I've screened, how many still need to be screened. And so I think what's super powerful about this is not only can you see who the top performers are, but you can also see how to, focus energy, learn from the top performer, focus energy on people who maybe are not performing as well. Or is there something else happening? Is there a demographic? Like I said, is there a location that we have that there's different barriers? So it really gives a lot of real data, and it does alleviate that perception. Sometimes we think, I think I'm doing that to all my patients. I think I'm always doing a good job at that. When you have the data, it's really hard to argue about it, and you can really see it. Next slide. So education is another tool we utilize. So we send out a monthly in our quality from the quality department. We send out a monthly kind of one pager that speaks to each measure that we're focusing on. So because it's always, you know things change, information changes. We want to make sure everybody's up to date on the best practices, why we're measuring that, what specifically is included in the measure, so we know the population and what we're screening for. And so this is something that goes out to all practices, managers. We ask them to put it on their huddle boards to talk about it at their huddles, so it's kind of a focus of the month. And then we also utilize uh, a champion, quality improvement champion at each site. And so, and I'll say for the clinic that was the highest performers, their champion is really a huge driver of making sure that people were educated. But these champions are usually medical assistants, and we meet with them every other month as a group, and we go through kind of education updates. We review best practices. It's a time for them to kind of talk together to understand kind of barriers and things to improve or ask questions. And then that really gives them the power to be subject matter experts and take that information back and disseminate that to their clinical team. We also want to educate patients because we can order tests and things like that, but if you don't understand why those tests are being ordered or what people are looking for, it doesn't have the same impact. And we know that knowledge really does have power, and so we remind staff as to the why these are so important, so that they can share that with the patient. And then we know that patients who understand or see the value in it are more likely to complete those tests or go take that extra step to go into the lab. And we also want patients to have the pertinent information that they need in their after visit summary. So for example, if there is something that we want to add in there, whether it be about diabetes or hypertension, we have a whole list of educational dot phrases that we can add to after visit summaries to help patients. I know it's hard to remember everything that you maybe heard in the visit. So if you have something to refer back to, that can be super helpful, or if a family member can see that as well. Okay, next slide. And so team approach, and I think, we want, the patient is in the center, but there's a whole team of people that are working to try to make sure that they're getting the best possible care. And so in quality, we look at workflow and try to optimize workflow and standardize it across the system. So if you go to one clinic, you're going to get the same care interventions as you would at a different clinic. We look at trying to empower the whole group to feel like we're all responsible. So if you're seeing a specialist, if the nurse is doing a blood pressure check, the medical assistant, the receptionist that greets you, we want them all to feel like they have a kind of a stake in the patient's care, and that they can all work as a team to make sure the care is being done. So those health maintenance prompts that I mentioned earlier, anybody who's in the medical record, can see ones that maybe have not been completed, and can help to encourage people to get those completed. So it really is a team effect. Okay, and next slide. And as far as incentivizing, so as part of the primary care provider's compensation, there is a quality incentive. And that amount is based on the provider's performance in those quality measures that we're tracking, that we have the data for. And the incentive amount, it directly correlated with their performance. And so higher performance receive a higher incentive amount. And so I think it really shows you're rewarding and valuing high quality care, and I think that's where we want to be. And it's great to incentivize providers to do what they're already doing and doing it really well. I think that might be my last slide. Dr. Oliver, I think you're on mute.
You know, I am on mute. Thank you very much. And there's a few questions that are in the chat. I'll ask you at the panel, unless you want to, jump in there and answer them yourself. But we have another participant poll before we get to Dr. Shannon. So let's pull that up, and I'll just take a second to load and have everyone answer that one as well. So here it comes. And the question's really about your health insurance carrier, your health plan, and the question is, are they actively managing chronic kidney disease to slow progression? And, if you know the answer, you'll know the answer. And then please submit, and then we'll keep moving along. So we got some answers coming in, so that's great. Thank you very much. And while you're still doing that, you can keep answering them. Let me introduce Dr. Shannon. Dr. Shannon and I have known each other for a while. We were on the community board for the American Diabetes Association. Michael's an endocrinologist by training, but he has moved into the more administrative world of. I basically say you run multi-care, but I know that's not true. But one of the things in one of the jobs, or one of the hats that you wear, you are responsible for the employee health plan and running that. So that sort of makes you act a lot more like a purchaser of care than necessarily a provider. But you got both of those things together. You got a lot of providers that you're overseeing, and so you've got a lot of members and a lot of people that you're responsible for, and so that experience of being an endocrinologist, managing diabetics, many of whom I'm sure got chronic kidney disease. I think all those things have played into your role today. So I'm going to hand it over to you to talk about, from an employer perspective, how you're dealing with this. And it may feel clinical to some, but we'll break it down and talk to you a little bit later.
Oh, thanks, Dr. Oliveira, for that. And so my main job is the Chief Medical Officer of Population Health for Multicare's 12 hospitals. But the 1 day a week, my main job is to run a health plan with my managing director. Next slide. And part of that involves managing CKD. So Multicare's employee health plan, it is, as of next year, 31,000 employees and dependents. It's a big plan. We employ a lot of people, and we spend a little over $200 million trying to take care of them. We administer this through our third-party administrator. First Choice is a good partner in doing what we'd ask, but we are a self-insured employer, and we consider that $200 million to be ours to be a good steward of our employees for their benefit. So we do have a small in-house team. It's myself part-time as a medical director with some help from Dr. Huang, one of my other physician partners. We have a program manager and a pharmacy director, and we have built an affiliated care management team of about 5 nurses and care navigators. And they're there to do the whole spectrum of medical needs for our population. But really, CKD was an area we identified early on. Next slide. And that's because practically it's about the money. It is a area that we were seeing an explosion of spend. We have at the time 24,000 people, and I've got 100 of those people that cost $12 million. And certainly there's altruism. We want our members not to suffer from going to dialysis, but most of us on the call probably have, about $600 per person per month to take care of a member. What we found is CKD 3 people cost us approximately $2,600, 4 times average. The CKD 4s, the ones, really advanced disease, it's $3,700. I don't think people understand the staggering cost in a commercial plan of dialysis. Dialysis companies make all their money on commercial patients. There aren't a lot of them because after a while, the majority end up on Medicare. But during that time, boy, it is expensive for the plan. That is not a typo. We were spending for 15 people roughly $46,000 a month for their medical needs. So about for the 15 people I had on dialysis, they were costing me $9 million. Or at the time, it was something like 5% of my health plan was spent on 0.02% of my population. An astute person would think, is there anything I can do to fix that? And it turns out, as Dr. Oliveira pointed out, you can do a lot to fix this, and you can do a lot to slow this. And diabetes and hypertension can be controlled and mitigated. And the question is what to do. I think many of us on the call who are self-insured employers get pitches all the time. We will fix your musculoskeletal needs. We will fix your mental health needs. And one of them we were getting pitched a lot was, we will help with your chronic kidney disease. And I thought, we're a health system. If I have to outsource chronic kidney disease, what kind of system are we running? And so we thought maybe we can build this in-house. And I recognize not everyone on here, if you're representing a government employer or private employer, can. But maybe this is you sitting down with your carrier and saying, build this for me. Next slide. What we did was we brought together a team of myself and Dr. Huang as medical directors for oversight, 2 managed care pharmacists, and we hired a nurse with years of experience at a dialysis center. Part of it was she understood what these barriers that people faced. She understands when they call and say, I was dialyzed yesterday and now I feel dizzy, how to handle them. But she also could help with people with earlier stages of disease, explain what could be coming. A large part of the cost is in what's called crash dialysis. If you know somebody is advancing, you can put in a catheter, you can set them up at a place that is less expensive. That is ideal. It's ideal is not to need dialysis, but what is ideal is to have a smooth transition over to dialysis if needed. Where we were getting killed is people going in on crash dialysis, being hospitalized while someone puts in all the catheters, and then going to a dialysis place that is much more expensive before we can stop it. Getting somebody out of a very expensive dialysis center is like getting someone off the wrong beach bar that costs twice as much they wandered into. It is a lot harder if you can get them before they sit down. And trying to do case management with our social worker that we brought over from dialysis to try to mitigate this and get them to a good nonprofit partner was a big part of strategizing as well. Next slide. A big part of this, though, did involve using our pharmacists. Preventing kidney disease progression is, if I say it's cookbook, it is like a cookbook. If anyone's tried to muddle through Julia Child's work, that is, the cookbook part's easy. It's trying to get the user to do it. That's a struggle. And it was the checklist of what to find. We had 2 good pharmacists to do the cooking, and it's finding people to get them on the right blood pressure medication. The right choice for diabetes could be a class. I'm not going to use any brand names, but I'm happy if people have questions, but I'm going to for now use generics or classes to put them on an SGLT2 or a GLP-1, a diabetes medicine with some benefit to the kidney, get their blood pressure controlled and their cholesterol with statins and blood pressure drugs, smoking cessation, getting the population for a changeable risk factor, and finerenone this year for appropriate patients has been added as something that would further slow the progression of CKD. Next slide. But equally important is to take people off of things that are hurting them. There are a lot of medicines that are bad for the kidney, and they're started for good intentions. Prior to endocrine, I did geriatric primary care. And one of the rules of geriatrics is every year is look at the med list and say, why is that there? And there's a lot of things, not only why are they there, but are they making my life easier? And trying to find drugs and maximizing their medication regimen and consolidating where possible, finding the drugs that have no reason to still be there, or they're the wrong choice for someone with kidney difficulty, because a lot of the drugs don't work as your kidneys start to fail, and getting them where possible from a brand to generic. But I'll show you two examples where, honestly, sometimes brand name drugs are completely worth it because the cost of the disease they're treating is far more expensive than any drug cost we could incur. We're just going to look at, next slide, two use cases. And one of them is a drug called dapagliflozin. It is a drug out there. There's two in the class. We happen to have our formulary for this one. And the study, very similar for the other, that looked at what happens to situations of importance to those with chronic kidney disease with and without the drug. For those who do not read Kaplan-Meier curves, God bless you, these are curves of survival. And the blue and red line, blue is with drug, red is without. And what you see is for progression kidney disease and heart failure, it's about 35% less with these drugs. All-cause death. People would say, what's clinically important to you? I said, well, death is pretty important to most patients. And recognizing these outcomes, we wanted to realize. So we want these for our patients. And we, as an employer, I made the decision to make diabetes drugs with benefit, the SGLT2s, the cardiac GLP-1s, and finerenone, free to employees. If they fill out our pharmacy, I absorb the entire cost because I want them to get these benefits. And what we found from equity is our people in lower income zip codes that are employees that were 3 times as likely not to fill, it got a lot closer. But we also want to see beyond the clinical, could this possibly make sense for me as a plan? So 3 years ago, Kelsey got me a Traeger smoker, which is pretty terrific if you've never had one. And my CEO got me 3 medical actuaries, which are even more terrific, less edible. But the ability to get some of these actuaries to come in and help me say, does this idea make sense? And the answer was, good idea, Shannon, or do not sign this contract, was a big help. Next slide. And we partnered with them to make a poster with the makers of dapagliflozin. Next slide. And this, by the way, we have no financial support from the makers. Oh, well, one more back. Thank you. Sorry if I was over enthusiastic or double click the mouse there. And if you look back one, we did a study and the company helped fund the poster itself, but we didn't receive any compensation. If you can Goldilocks that, one more is just right. It will be look like something no one can read because they're not meant to. We'll get there. There you go. Thank you. So if you look at this, you're not meant to. This was a look at the overall study, which is, what's the budget impact? If I spend all this money on drug, what am I going to get out of it? And by the way, the answer doesn't always have to be not all things are going to be profitable. You do the right thing, it's the right thing, but boy, it's nice when it does. Next slide. And what my actuary found in partnership with myself and Kat, my previous executive director, in green is what we pay without taking the drug. In red is what we pay with it. And that includes the cost of the drug. And what we found for this 100 people, if we chased them and got them on drug, was we could save across 3 years millions of dollars getting them on this. Slowing kidney disease is great for everyone who doesn't own a dialysis center. It is great for the patient. It is great for us. And it turned out it was great financial success. So for those of you self-insured employers, there's ways out there, and either your broker or your TPA should be able to be a partner to help you find these. Next slide. The other part is to kill an error is equally valid as to try to add something new. There is a class of medicines out there called DPP-4s. They lower sugars a little bit, and they don't do a lot else. They don't slow dialysis. They don't reduce heart attacks. They don't reduce strokes. They don't reduce death. So here we are spending, I don't know, probably $10,000 a year on drugs that have pretty limited usage. And we said, What if we try to transition all these people off of them to the other two classes that have benefits? What did we do? And Jennifer talked about smart sets. We partnered with our cardiologists who were not, initially enthusiastic users of diabetes drugs, but we were able to see them as cardiac drugs for persons with diabetes. And by getting people transitioned over, we were able to get about $600,000 in cost avoidance. You can do a lot to reduce the progression of kidney disease. And you can do a lot with your team or you build one with someone else. You can do a lot with figuring out what can save outcomes. And oftentimes those outcomes price out. Sometimes they don't. But we want to do the right thing by our members. But if doing the right thing by the members means salvaging the plan, which I always tell our employees, every time I can make something reasonable that makes both of us win, it means your premium dollars next year are going to be more moderate. I take pride. For 3 years running, we have increased 0.5% per year of our commercial spend by aggressively running the plan. So 3 years running, we are up 1.5% in spend. And we do this by helping make our members partners. And I encourage those of you who are self-insured employers, it can be done. And I encourage you to partner with your TPA, your broker, or bring it in-house. And with that, I'll turn it back to Drew.
This time I'll go off of mute. So we'll go into a little bit of a panel discussion. And while we're doing that, participants who are listening, make sure you have one of these phones, because the next poll question will require you to do a QR code, and that will allow you to answer that question. We had a couple of polls before, and the first one was, how much more does end-stage renal disease cost than non-end stage renal disease? And as Dr. Shannon, puts up, he's got a 5.0, so it's somewhere in there. And he also talked about where people get dialysis can make a difference as well, because the cost of the contract or the cost of care can be wildly variable as compared to Medicare, which is a pretty narrow cost structure. Commercial can be highly variable. So then the question was, what are my carriers, are they actively managing it? And 40% of you said yes, so that's great. Like Michael's group, you would say, yep, they're actively managing it. But then the other 60% either weren't sure or it was like, no, they're not. So this should prompt you to go talk to them about, okay, how are you guys managing chronic kidney disease? Are you managing the medications aggressively? Are you managing screening? And then my question for Jennifer is, one of the questions that came through was, is there an incentive? And you answer that internally. I guess my question would be, is there some incentive from the purchaser of healthcare, either the plan or an employer group, that was driving you to create that incentive for your providers within Everett Clinic or Poly? Can't hear you. I think we got you double muted. Yeah.
What did your payers do to motivate you, and how can I get in on this?
I think that's what we want to know. And unfortunately,
what carrots? Yeah,
we have a little technology thing, but we'll have Jennifer keep clicking and seeing what happens. No, not yet. I don't know what's going on. She was there before.
She took some prop and waved some dollar bills, because that's part of it. Is, well, how do we reward providers that are helping us?
Yeah. So what do you do, Michael? You got a bunch of providers, and you got your 31,000 employees and their families, and you've got pretty aggressive things. You talked about the cardiologist. From an education standpoint, we know from quality improvement work, you educate people, and then 2 months later they may not follow up and do that. So you almost have to put systemic things in, like Jennifer was doing with the EHR and sort of those best practice alerts. What are you guys doing at Multicare to try to incent the providers to do all the things that you just mentioned that are saving you, millions of dollars?
Are you asking for the WIFM, the what's in it for me? Because I don't blame them. If you go to your average, I did geriatric primary care before endocrine, and it was easier then because you saw your patients, did your notes, and maybe you had some Medicare Advantage contracts mixed in. I cannot conceive of what it'd be like to be an average internist or family doctor with 10 different plans asking for 17 different scoring metrics. And what am I trying to do? I'm trying to sit at the bar and get my arms out and get the most share of their attention possible. That's what's reduced to. And I think the morale of my primary care doctors approaches that of my father the last 2 months of Vietnam in the infantry. It is hard to be able to sit there with them and say, see more patients, get these measures done. And also, by the way, if you can make patients happy, that'll raise our CAP scores. So what you can do is generally have providers have a bundle of 5 to 7 things you incentivize them on. The other part is most providers do not want to wake up and say, oh, wait a minute, this is the Aetna person who's special for this one, but this is the Cigna one, and we need to work on tobacco. It's absolutely not possible. So you build stuff in the back that gets them out of it, which is you go and see your patients. I will serve up the people for you that I would like you to help. So we serve up the ones that is, hey, by the way, can you put this person on this drug? Do they know it's an employee? Maybe, maybe not. So you have to build the team in the back to feed it up to them. We incentivize providers on A1C and blood pressure control. We do not yet incentivize them on microalbumin screening. I don't know if it'll get there. If Jennifer is live on audio, I would like to know what could motivate them so that I can get my my non-sugary donuts out. Okay.
No.
The CMS. Yeah, Jennifer's point is most people are going to have the similar it's not like somebody is going to say your A1C should be down at 8% and someone else is going to say, what's an A1C? Most plans have some similarity. Get your vaccinations, get your colorectal cancer screening, get your mammogram, get your A1C, get your blood pressure. None of these are, get your chlamydia screening and get your, there's the ones mentioned as well, for sure. The smart set, so BPAs, there is no quicker way to achieve results and to enrage your providers at the same time. So BPAs have to be, if you put in too many BPAs, you will get like a March 15th for Caesar treatment by your peers. And so the thought of trying to, what are the 5 most important or 10 most important? Because everyone has their incentive to put their BPA in. The pediatrician wants it for the well child. Yes, careful and sparingly. Is a very fast way to engender enemies. They work. So like I said, you pick the ones that if they get incentivized on it, there may be some motivation. But yeah, a BPA's injudiciously used is one of the quickest ways to enrage providers. Is anyone familiar with the story on the Rhine River that there were these things where everyone on the Rhine River would have a castle to collect a toll, and over time the number of tolls was so great that nobody actually put shipping on the river. We'll try to pick a less obscure reason, but the concept of each of these being toll booths to take the provider means you have to only have so many, or else the provider can't get the boat down the river. Yeah, and the comment about primary care buy-in, yes, it's them who's going to be executing it and clicking through it.
Yeah, so it sounds like having a course set that applies to all patients, because I remember in practice I had no idea, who I was, seeing or what insurance they had, or if they didn't have insurance at all. Sometimes I would get alerted on that one, so I could maybe do something differently, but it was always tough, right? So I think, you're on the right track. It sounds like Jennifer, you do the same thing, which is, hey, we're going to just try to do the right thing. We're going to put the right alerts in there. We're going to put the right things in for the patients, and we'll let the carriers, hopefully pay us for that, or maybe put us at risk for that in the future, so that we can pay ourselves for that. How about any? I put a slide in there on sort of the impact of people of color and kidney disease. Is anything, Michael, and I'm sorry, Jennifer, anything, Michael, in your data that, or your work with the social worker or the nurse that we could learn from those populations?
So you are correct, and it depends on how well you drill. So I don't have the renal data specifically, but when we looked at our most admitted hospital, my biggest cost patients, by language, the group that was driving us was Russians and Ukrainians, Russian Americans. Well, these are first generation typically because they're picking the language of choice. That's a hard group to pick out of a different group. It was one where we really struggled, and I have still not mastered great community outreach. The other one we discovered is Southeast Asians. You mentioned the dialysis part. I worked at Harborview for 6 years, and the answer of why Laotian, Hmong, and Cambodian kidneys seem so blood pressure sensitive. You would have these people who make me look husky come in, and with 190s over 100s, and they would just, unfortunately, so many of them we failed to identify earlier. Cambodian American and Ukrainian Americans and Russian Americans are the ones we've identified the most. Am I really proud that I've done a great job of outreaching to employees, especially dependents who are more isolated and less healthcare savvy? I do not think I've done a great job yet. So that's an honest. There's certainly the other broader groups about African. We see more of that, but those were the two surprises I didn't expect, and that my data, when I did it by race, didn't pick up. But when I did it by language isolation, it did. King County, I think, has done. I was able to meet some people in King County, some incredible work on language isolation with dental care, and I can learn from them.
Yeah, absolutely.
Smart sets.
There's a question in the chat about, do these smart sets, allow people to follow guidelines more closely? And I think Jennifer just answered that. They help you evolve the guidelines. I think it does help, put evidence-based practice, sooner than it takes most of us to learn it, which I think the average was 14 years before evidence becomes practice. So I'm glad that's in there. And I think it also helps you with, new medications or appropriate medications that might be on your formulary that for your employees, so that you can steer people to the right things that are going to cost them less as a member cost share, for sure. Before we get to the last question, any either plan barriers, internal barriers, or maybe a key lesson learned that you'd like to share with the group before we get to the last poll question?
Yeah, there aren't any nephrologists. So the big part is people will say, well, just send them into nephrology. My nephrologist can't keep up with the number of people they're dialyzing. And I recognize that. I practiced in Olympia where there were 500,000 people and 2 endocrinologists. And sometimes we did things like biopsy thyroid. So there were 50,000 persons with diabetes and 2 endocrinologists. So the big thing is, what can I build? And the truth is, most of this stuff doesn't need a nephrologist. It needs a competent, capable primary care group supported by people to help them do their job. That was the biggest part. We didn't involve our nephrologists. It wasn't like we were doing something that they thought but we didn't need them, involve them, and they dialyzed people. Oh, nephrology is a miserable life. The number of times I got woken up to go in the hospital at 2 a.m. was once a year. I don't envy that. And so when you go to approach them and say, I'd like to change your world, it's hard to engage them because they feel totally besieged and overwhelmed. Maybe the Clinic Optum ones are currently waking up one day and saying, how can I change the world? I think they can't get out from under that. And there's some good people at especially Everett Clinic that I did residency with at UW, but I think that's the biggest one is you can't count on your nephrologist because they can't do it.
It's really, leveraging your primary care infrastructure and those teams that are there. I saw Jennifer with a vertical head nod going, so I think I'm on the right track. Using specialists when you absolutely need them, and then letting those higher level specialists do the work that they do. And yes, I think having ARNPs, other, broaden that team out as much as you can to actively manage those CKD3s and 4s is key for sure.
What I get when I approach them is, but they can't take call. And I said, I don't need them to, can you just have them do all this that you'll never get to? And that's the one we've gotten the most is they can't take call. And I get that. But that's not the problem I need them to solve. But that has been our biggest, but hiring nurse practitioners to do that checklist. But I have 2 great pharmacists who can pinch hit decently pretty well. They can't do some of the things that a nurse practitioner can do though.
Sure. Well, I want to thank, before we get to the last poll question, Jennifer, I'm so sorry the audio, for whatever reason, isn't working. We can see your smiley face. We got the vertical head nods. We got some good chats in there. Michael calling in from the other side of the world, actually. You've gone above and beyond, and great information from both of you, as always. We'll be sending the deck out to everyone. The recording will be made available as well. And let's go to the last poll question because it'll just be fun. So everyone get your phone out. And there's a QR code. And so you go to your camera, Let's see if I even can do this. Yep, looks like I even can, so that's good. It worked somehow. If you can't do that, you can actually go to slido.com and put in that number, and that will do it as well. And it may take you a little, minute or so to get in there. And what we want to do is create a slide, a kind of a word puzzle type slide. And so when you go to Slido, you can just put in that number, that 2957089. Then you should be able to start putting words in there. And I see someone has gotten in there. We'll let this keep going a little bit longer. Thanks for putting information in there. Again, this is following evidence-based guidelines. It is a preventive service, but it's if we didn't get anything across, we want to screen people so that we can, identify them. As Jennifer mentioned, patients like to know where they're at, so that they can also take ownership and share in some of that decision making. That will help them understand their condition and be able to say, hey, how come I'm not, I should be taking these medications. I should be doing X, Y, or Z. I should actually read that, piece of paper that you just printed out for me as I was being discharged. Now Jennifer's laughing at me. All those things I think are really important. And I want to thank you both for joining us. And we look forward to the next one in a couple of weeks on colon cancer. Thanks again, Bear, for supporting us on this as well. And I hope everyone has a great rest of your week. And hopefully we get summer to continue a little bit longer. Thank you very much.